Today we're going to talk in my last one a little bit about pain and analgesia. And like we do every couple of years, we try to update to see if there is anything new, like we've done in the previous ones. For pain and analgesia in the emergency department, not too many things have actually changed in regards of newer medications. Maybe there's two that I'm going to mention at the end. However, what we've noticed is that most of the issues related to pain and analgesia in the emergency room had nothing to do with having newer or effective medication. It has to do with us. So the newer thing with us is that are we thinking how we're thinking the same way that we were 20 years ago, and we want to keep doing it that way, so we're not using more management of pain in kids, i.e. they can take it, or are we going to change once and for all our behavior to try to help the kids the same way we help adults? So as usual, we're going to do a lot of experiment. We're going to have a couple of patients that presented to my ED and probably is going to present it to your ED. And I want you to think. You don't need to tell me because we don't have the time, but what would you or what do you know it's done for these kids when they come to an emergency department here in Jordan or any other part of Jordan? So the first one is a little kid that has a cut in the eyebrow. What do we do for them? The second one is this child that fell off a tree and broke his arm and is angulated and he presents to the emergency room. The third one is a child that has to go through a CAT scan and is a little bit agitated and intimidated because of a CAT scan. And the fourth one is an abscess that needs to be drained. So I gave you 4 cases, very common cases that happen every day in any emergency department. Now here comes the challenge. If the first one with the suture, what you're doing is infiltrative anesthesia. In other words, you put in Lidocaine into the wound with a little needle, and the child has to be restrained because of the crying, not necessarily after the anesthetic because they're scared, number one. If the second one continues to cry and remembers what they did when they have to fix the arm in the emergency room. If the third one had to be anesthetized by anesthesia to get the CAT scan, and the fourth one was drained just with a little bit of a local on top and nothing else, we're probably practicing medicine in the early 80s. Okay? That's how behind we are if we're practicing that way. That's the dissonance, that's the challenge. So why and how can we change? Well, the first thing that we need to remember in pediatrics is that, like in adults, it's a sensory and an emotional response when the kids are exposed to pain. So all this trauma that we talk at adults when you have a big motor vehicle accident, think about it as a child that is taken to a strange place to have a little cut because they were playing. Now 3 people are on top of him or her trying to hold them down. Here comes a needle right to my eye to try to infiltrate that laceration. And then on top of that, a bunch of people are holding me while I see this needle coming and threading. That's post-traumatic stress disorder to the max. So until we don't start understanding that pain in pediatrics is also an emotional problem that we have to treat, we're going to get not in the right page. The sad part is that we know for a fact that we have the tools, we know for a fact it's being treated all alone, but the way we think is that what is preventing us to take care of pain in pediatrics. I'm just going to give you an example. Look, I love history, and if you go to 6 BC, before Christ, you see how they're taking care in the Diomedes, in one of the wards, how he's taking care of a little boo in the finger. Actually, if you go closer here, Mesopotamia, this is opioid seeds, okay? So we knew that the opioids were there already all that time. If you go to the Greeks, look how they use a immobilizer in their arm. Yes, we go to the Renaissance, and this poor guy is being treated for migraine by a trepanation in the forehead because they want to release the humors that this person had inside the head. However, if you keep going through the history of pain management, we start to do things that make sense. Teeth begin to spring very fast because of the warmth of the air, and rubbing fingers and applying virgin wax in the gums helps with teething. What they're doing is basically the same thing that we use now when you're teething with the teething rings. And what happens is they didn't know it at that time, but pain, vibration, and pressure go in different fibers. So if you use certain fibers, the other ones get blocked. That's why every time you hit yourself in the elbow, the first thing you do is you rub your elbow to try to ameliorate the amount of pain that you're getting. However, I don't know why, but as we get older and we think more, we start making assumptions that have nothing to do with the way science goes, but the way we think. For example, this is from 1868. The hospitals in the East, and it's going to remain nameless. Children, again, through one respect, the most irritable of the human race, are some others the most free from irritability, chiefly directly against sudden and acute pain. Thus, children may be confined to a rigid bed, even sometimes in unusual positions for months, without suffering any respect to the spirits and general health. This is our thinking in 1868. Now, at that time, we had morphine. But if we think that the kids can't take it and they have to be restrained, we will not use them in kids. We'll use them in adults. So my question in 2018, let's see how you guys respond. So the first slide is this one. The second one is this one. And the third one is this one. Okay, did you notice that on the third one you just did this? Wow, look at that. But this child is not crying. This one is, and this one is. But we're used to the babies crying. So since we're used to the babies crying, do we need to do anything for the pain? Because this kid is screaming bloody murder because somebody's putting an IV on them. And this one is very relaxed after a broken femur because he got fentanyl on board. So you will treat who you think needs treatment in pediatrics. And that's the bad part. Because adults will say, it's hurting here. Hence, they expect you to take care of the pain of an adult. In a child, you are the judge of pain management. So if you don't think the kid needs to have pain management, you may as well stand up and let's stop the conference right now. Because if you don't change that behavior, you continue to do the same thing that we did before, okay? As a matter of fact, the question is, why do we still do lumbar punctures without anesthetics in babies? Don't tell me that we don't do LPs without not putting lidocaine in a 2-week-old. Oh, because I learned to do it that way. Oh, I'm not going to miss on the first one. Yes, why don't they put the needle on your back and see if you're not going to miss the first one with you, because I'm pretty sure you want anesthetic on yours. Why do we keep infiltrative anesthetics when we don't need to use lidocaine injected in the face anymore? I mean, in other places, why do we discharge patients from the emergency room if they came originally with pain, with no pain management? I.e., they come, they have a severe otitis media, we give them antibiotics, but how are you going to take care of the pain? Oh, just, I don't know. Well, I'm just trying to challenge you. Because a lot of the people have created a lot of excuses and say that it's lack of research. Well, as of to yesterday, there were about 762 papers in the PubMed referred to analgesia and pediatrics. Okay, so there's plenty of papers. Knowledge, I don't know if you have read the 700, but there's plenty of people that read about them. And to assess the pain is difficult in pediatrics. Well, are these two kids in pain? No, they're happy, right? So I think if you take all these things, for me, that's pretty much an issue of culture and knowledge. In other words, it's becoming negligence, that we know that we need to do something, but it's easier for us to stay in our comfort zone of what we've been doing for many years and not challenge the status quo to make things a little bit different. So that was the moral, social part of the story. Now, what can you do to take care of pain? And we're going to start with the prevention and anxiety. There's a lot of things that can be done before you begin. Application of cold, relaxation is huge, vibration sometimes helps. I'm just going to give you some samples that you don't need it, but this little thing in here is called a needle blocker. Basically what it is a piece of plastic that has a lot of plastic little teeth. If you put it on the skin go crazy thinking that there is a lot of different stimulation, and you can put the needle in the middle and you barely feel the needle because the sensation of impulses gets confused. Now, what is interesting, everybody says, so what is that? Well, that's what I call the very old iPhone. Everybody comes to the emergency room, and before we used to have these play stations with lights to distract the kids. Today, you have the best weapon on planet Earth. You have a phone, you have YouTube, you have cartoons, you have something at your hand. Let the kid play with the phone. Let the kid be distracted. Let the kid be in an environment that they feel comfortable, and that helps them to adapt to the situation. Now, let's just go quickly through the different modalities that we have to finish. What do I put there? Sucrose. You heard me say this before, and if you haven't used it, shame on you. But sucrose basically comes in a little thing. You can mix them. The solution is about a 20% sucrose solution. You put water and sugar, mix it. In less than 3 months of age, is as good of an anxiolytic agent as Valium. So if you're putting an IV and you want to calm the baby, you have this sugar water, you put the pacifier or the finger, give it to the baby every couple of seconds, and the baby will calm down. As a matter of fact, when you're doing a spinal tap in a baby, what we do is we put, and we'll talk about EMLA first, then we infiltrate with lidocaine. Then we ask the mother, while we're holding the baby, the mother uses a pacifier and give him the sucrose to calm the baby down while we do the spinal tap. And yes, the mother stays in the room all the time. Okay. Non-opioids. The acetaminophen, I think in here is paracetamol, right? And the issue, it's a good medication. The problem is that we don't use it the right dose. The dose of paracetamol for fever is being studied at 10 milligrams per kilo. For pain is 15 to 20 loading dose. Then the maintenance is different. And per rectum is different. So what happens is, if you're going to use medications for pain, make sure you use the right dose, because we are using temperature when in reality we need to use pain doses, okay? Rectal is much higher. The next one are the non-steroidals, ibuprofen and others. If you're using the ibuprofen, the loading dose for pain management is 15 milligrams per kilo. Ibuprofen works differently. They inhibit the peripheral oxygenase and decrease prostaglandin, so they have better in the anti-inflammatory phase than the Tylenol or the acetaminophen does. Can you combine them? Yes, because they are two different mechanisms. The reason why people don't combine them is because they're used to the fever, that they try to dance with the Tylenol and ibuprofen for the fever control. That's called fever phobia. Fevers don't hurt. But if you want to do it, that's up to you. But if you have nothing more and you have someone in pain, if you give them both at the same time, you're using two different mechanisms to attack pain, hence you have better results. If we keep moving up, it's the opioids. And the ones that we use more frequently are morphine and fentanyl, okay? Yes, a lot of people are worried about the opioids because of the cardiorespiratory components. You have to make a big error giving them, and you have to make a big dose mistake giving them to get the respiratory depression with them. These are the purest forms of analgesia. We use them all the time. As a matter of fact, any child that comes with that broken arm, what it will happen in our place, the nurse will put a splint to avoid more movement, okay? So we don't have an arm that is broken and moving around. And nasally, we will give them fentanyl in triage. So by the time they come back to the emergency room, they'll calm, they have no pain, they can go to x-ray, then they can come back, and then we will do this conscious sedation to reduce the fracture. But there's absolutely no reason to use opioids in kids. The problem is you have to be comfortable with them, and you have to know your doses. And in morphine, for example, is 0.1 per kilo. However, one caution, opioids work by saturation. So it's like having a half drunk in your house or a full drunk people. You, because of culture, may not have too many of those, but also in the United States, we have to deal with alcohol a lot. And I tell you one thing, you'd rather have someone completely drunk that is quiet in a corner than someone that is arguing all the time. So what happens with morphine, if you don't give the correct dose, what you're doing is you're partially blocking, and you get this anxiety issue because you're not controlling the pain completely. And in pediatrics, for some reason, it's been studied, if by any chance the child weighs 15 kilos, and you have to give morphine, right? It should be how much? 1.5 milligrams. Well, guess what happens? People give 1 milligram. So we round up for antibiotics, but we round down for medications for pain because we're scared of the medications for pain. And then we're not doing the job that we need to do with them. Fentanyl is even more strong. We use 1 to 3 micrograms. It can be nasally given, it can be orally given, it can be IV given, it could be IM given, it could be endovenously given. So access is not an issue. Oral ones, these are the ones that are in the market, and you need to be familiarized and pick one of them to decide how you're going to take care, because not all the pains will be able to be taken care with Tylenol and or ibuprofen. So you need to have in your repertoire a opioid that can be used orally. Okay. The only caution with the opioids is the neonates. Please monitor carefully if using less than 2 months, because they do not metabolize as well. Let's say now that you have gone through managing the pain to now doing local invasive procedures. What are the options in 2018? First one, emlacrin. You're probably familiar with it because of the cancer patients. This was designed and discovered first for patients with portocath. You put the cream before the portocath was accessed to get samples in patients that have lines, cancer, hematology, or oncologic issues. The issue with EMLA, it only goes below the stratus corneus, so it doesn't give you deep anesthesia. And it cannot be used for lacerations because it's not water-based, it's oil-based. But where do we use this? Before spinal tap, we use EMLA in the site. So when I do then the infiltration with lidocaine in a needle, the patient doesn't hurt that much. If you're going to do an IV, I can put it in there if I have time to avoid the pain. If I'm going to access a portocath in a cancer patient, then I put it before. That's EMLA. The ones that we use like water, and the formulation is in the internet, and it's very easy to prepare by any pharmacy in any hospital, is lead, which is lidocaine, epinephrine, and tetracaine. It's a gel, and that's what we use for local anesthesia in 90% of the wounds in children. We do not do anymore a needle with lidocaine. And I go a lot to different countries in Latin America, and they say, we don't have it. We don't have it. And until one day I got so upset in my country, so I have the right to be upset in the Dominican Republic, so I actually walked out, went to the pharmacy at the Children's Hospital that has very low resources, they have not too many, and I asked the pharmacist, can you mix this with what you have right now? And say, it will take me 5 minutes to do it. They had it since then, and it took them 5 minutes. So all what it took was somebody that was a pain in the butt, myself, to say enough is enough for you to keep saying that you don't have it. Take the formula to a pharmacist, and they mixed it right there. It's the easiest formula on planet Earth, and you do not have to infiltrate kids anymore with lidocaine. You put this gel, wait 30 minutes, and do any suture you want in the face without doing anything else. Okay. Last thing for anesthetics is, if you're going to use them to infiltrate, don't stick to one. Because if you're going to do a finger and you use lidocaine, the maximum amount of time that you have for blockage is about 30 to 60 seconds, okay? Any one of us who have removed a nail or suture a nail bed knows that 3 hours later, that thing is throbbing. So make sure that you use an anesthetic that is a little bit longer acting, so you can give something orally, so by the time the oral agent is working, the anesthetic is wearing out. Not the contrary. How do we take care of things? Oh, we suture, go home. 2 hours later, the poor family is calling, the kid is in pain. Oh, why don't you give him Tylenol or ibuprofen, versus saying, I'm going to give you a longer anesthetic. Please use immediately ibuprofen at 50 milligrams per kilo every 6 hours, so by the time the anesthetic wear out, the ibuprofen or the ketorolac or whatever you're using is already in. It's just pharmacokinetics, guys. Now, last part of the presentation. What about if we need to do not pain, but we need to do sedation? We need to do the CAT scan. In other words, you need to ask yourself, is this procedure painful? So I need to give sedation and I need to give analgesia. Is this patient needs to be completely motionless, i.e. I need to do an MRI for a long time. What's the duration of the procedure? Because most of the stuff that we do in the emergency room don't want to be more than 45 minutes. What's the level of expertise of the practitioner performing the sedation? If you've never used ketamine, don't take one day to practice with ketamine. Observe the patient first. And what's the MPO status? So, what are our choices for sedation and anxiolysis? Okay, first one, benzodiazepines. We use Midazolam. This is an anxiolytic agent. It is not a hypnotic agent. It is not an agent that is going to put you to sleep. If you put somebody to sleep with a benzodiazepine, you're giving too much. So whenever you're saying, I'm giving Versed, Midazolam, I'm giving Versed, and he's not sleeping, you're doing it right. Because if the patient is sleeping, you're giving too much. These medications were designed to calm you down, not to sleep you down, okay? And we use the oral form a lot. As you can see in there, it's a very high dose because it goes through the liver. Please be careful when you use these doses, okay? Because look, the IV form is completely different than the oral form by a lot. So if you give the IV form in the oral calculation, you are going to definitely get somebody in trouble. When do we use this? You remember the first kid that came with a cut in the eye? That kid is anxious. As soon as you get to triage, you get midazolam syrup, or you can use the midazolam that comes with the IV syringe, the same one, the IV medication. You calculate it, you give it to them. And in 20 minutes, that child is relaxed, is happy. On top of that, it had that little cream that I told you, right? So now I can suture this child without him or her crying, with nobody holding them, and no pain because I didn't have to use a needle to infiltrate the eyelid. That's how we do in 2018 facial laceration, and that's how we've been doing it for the last 10 years, okay? Next one is Nembutal. These are barbiturates. They're potent, but this is if you need a quick, like a CAT scan, use it, sleep, come out of it, and I'm not gonna spend too much time because there are other options that we'll mention later on, but the dose is 2 to 5 milligrams per kilo. Etomidate is an ultra-short, non-barbiturate hypnotic. Etomidate is used a lot in rapid sequence intubation. But in pediatric emergency medicine, we do a lot of reduction of shoulders, elbows, knees. And if I need an agent that is going to knock you out because it's hypnotic, and then I do the procedure, this will be one of them. Like, for example, to put a shoulder back in place, it takes me maybe 15 to 20 seconds. But it hurts a lot. So first we start with morphine to take the pain away. And when the patient is ready and comfortable, it's not hurting that much. Before I do the movement to put the shoulder back in, give him etomidate, sleep, pluk, in. What happened? And in 30 seconds you awake, okay? So that's what we use etomidate for. There are other drugs that I will not recommend because if you're not doing even basics, don't go here. But Propofol is used. We use it a lot. We call it milk of amnesia. But the only problem with Propofol is if you're giving Propofol, you can do nothing else. If I'm giving ketamine, I can do the suture and I can actually sedate the child myself. But if I'm giving the Propofol, I need to be 100% in charge of that airway because Propofol can be very depressing for the airway. Other agents that are being studied, Precedex and methoxyhal, they're available. And there's still not enough information for peds, but the ICUs, we use it like water, and I wouldn't be surprised if the first one, this one here, is going to be the one substituting a lot of them because, for example, etomidate has no pain, but is a hypnotic, and the Precedex have pain, hypnosis, anxiolytis, and amnesia. So this is like a big package for management of serious wound. Okay. So remember our case. So if we need to do now complete control that can provide me pain and sedation, ketamine is our number one at this point if I were to recommend one to you. Because ketamine, I don't need to combine. There are other people that use fentanyl and Versed. that has higher risk than ketamine alone and provides similar results. Ketamine is a dissociative agent, basically stops all the pain that goes through the fibers and sensation of pressure to your brain. So you can actually do a lot and the patient will not feel it. It protects their airway very well, and all these things that increase your intracranial pressure, your gastric pressure, and your eye pressure, baloney. It was studied and it does not, okay? So our main weapon right now for cure of burns, lungs lacerations, the reductions of fracture is ketamine. The dose that we use intramuscular is 2 to 5 milligrams per kilo and intravenous 0.5 to 1.5. However, once you start talking ketamine and once you start talking propofol, you need full sedation protocol for monitoring, okay? And that's the last step for the talk. Nitrous oxide, we have it available, but the issue with nitrous oxide is you have to spend money in a scavenger system that takes the nitrous out of the place that you're working. The patient needs to cooperate like it says in there, and if you use a mixture to 50%, it's equivalent of 5 milligrams of morphine. The problem is that if you don't have a good scavenger, in about 5 minutes, the patient and you will be both very happy and laughing at the same time because the gas stays in that room. Okay, so we have it. Most of the time we use it for burn cures, for smaller foreign body removal, and for a little bit of sedation after we've done a block with the abscess, for example. So, what are the current guidelines for safety? First of all, people need to be trained on sedation. Not everybody can go and do it, but you don't need to be an anesthesiologist to do it. In our emergency room, we do all the sedations. We do all the pain. The anesthesiologist is a good friend of ours. They trained us initially, but they need to stay in the operating room. Because if you bring an anesthesiologist down to do something in the emergency room, you're just wasting OR time and another precious time for a child that needs them in there. Second, we need to define what are we comfortable in the emergency room. Conscious sedation is what we do. We don't do anesthesia in the emergency room. I don't take you to plane 4 where the airway can get spasm and compromised. We basically take you down enough that I can control all the pain, that you're breathing on your own, and I'm monitoring your oxygen. Now, what do we do then? We need to have personnel, equipment, documentation, and the fasting. The fasting in the emergency room, it's different from the OR. OR has the luxury to say, don't eat after midnight. Well, if I say that to my patients, nobody will show up after midnight. So, you know, we assume in emergency medicine that every stomach is full until proven otherwise. But if you want some of the guidelines, 2 hours for clears, 4 hours for breast milk, 6 hours for non-human milk and solids, it depends on the scenario. If it's a badly broken bone, we will sedate this child. If it's a little cut, we can wait. Okay, so you have to balance the act depending upon what you're going to do. Now, what is new and is important that it's incorporated in the sedation protocol monitoring is capnography. Before we used to do pulse oximetry, but we noticed that if you give oxygen to a child and you only have a pulse oximetry, the pulse oximetry can be reading 100% because of the oxygen that it's getting, yet that patient can be hypoventilating. And the CO2 was found to be very high in some of these kids sedated. So with the nasal capnography in the nose, while your kid is sedated, you can monitor the oxygen and the CO2, and you know exactly what the respiratory status of that patient without getting into a risk of respiratory insufficiency. Okay. It's done. Here we go. The discharge criteria for sedation is they have to go back to how they began. In other words, their cardiovascular function and airway needs to be open. They should be easy to arouse. They can talk. They can sit without any help if it's an age that they can sit. They can drink well, and if by any chance, for accident, we have to use a reversal agent like naloxone or something like that, they have to be observed for a full 2 hours. I didn't want to leave, and where's my friend? Guthrie is not here, without saying, remember, even with the sedation, you have to use your cardiopulmonary assessment, okay? Because that's how you identify these kids in trouble or not. So what did I try to say today? First of all, I can talk a lot from history, and I can give you a lot of medications. I can tell you that most of the time, the problems is not related to the medication availability. Most of the time is our culture, that we keep doing the same things because we were trained this way. But guess what? Things change in life, things change in medicine, and the ones that are the hardest to change are the minds of the doctors when new technology and new options come that make you feel uncomfortable. Well, it's time that we get uncomfortable when it comes to managing pediatric pain. With this, I thank you very much. This is my last conference with you guys. It was a pleasure to be here and hope we can get to see you soon. But the next time I come, those 4 cases, you better be treated in a different way. Have a great day.